Most people believe that if a radiologist looks at your MRI or CT and finds something wrong, the answer is clear. Fix it. Schedule the procedure. Trust the image. I used to believe that too, until I started listening, not to the patients coming in for their scans, to the doctors reading them. A colleague with 18 years of spinal imaging who told me quietly, "I would never let anyone do that to my own back." A radiologist friend who referred a patient for surgery and spent 3 weeks wondering if he'd made the right call. I started keeping count. 1 conversation became 5. 5 became 10. And when I asked 10 radiologists, people who spend their entire careers inside the images of the human spine, every single one gave me the same answer. Not similar answers, the same answer. My name is Dr. Ivy Ellington, and I'm a musculoskeletal radiologist with over a decade reading spinal imaging. And today I'm going to tell you the truth about the spinal procedures that the people who see everything, who read every scan and understand exactly what those images do and don't mean, would never agree to for their own bodies. Here's what most patients never get told about spinal imaging. When you go into an MRI machine, the scanner doesn't show you pain. It shows you structure, discs, bones, soft tissue. And here's what stops people cold. Studies have scanned the spines of people with 0 pain, people who felt completely fine, and found that over 50% of adults over 40 had disc bulges. Over 80% of adults over 60 showed degeneration. No symptoms, no complaints, just findings. Radiologists have a name for this problem. Incidental findings. Things that look significant on a scan, but may have nothing to do with why you came in. And in the spine, the gap between what the image shows and what the patient actually experiences is wider than almost anywhere else in the body. The danger isn't the finding. The danger is what gets done about it. I want to be clear about something before we go further. A spinal finding is not automatically a reason to do nothing. I've read scans where the image told me exactly what was causing someone's pain, and intervention made complete sense. The question is never whether the finding is real. The question is whether treating the finding will treat the person. Those are 2 very different things. And that distinction is going to matter a great deal right now. Procedure number 1. Multi-level spinal fusion for degenerative disc disease. Here's what the recommendation usually sounds like. Your MRI shows degeneration at multiple levels. We need to stabilize the spine. For certain patients, those with genuine instability or progressive neurological deficits, fusion is exactly right. But here's what the scan doesn't show you. Degenerative disc disease is not a disease. It is a normal, expected part of aging. Virtually everyone over 60 has it on imaging, and the same findings appear in people with no pain whatsoever. Multi-level fusion carries a complication rate most patients are never told about. Studies in the journal Spine documented complication rates exceeding 40% for complex procedures in older adults. Hardware failure, infection, blood clots. And in something called adjacent segment disease, where the vertebrae above and below the fusion begin breaking down because the spine's natural mechanics have been permanently altered. The hardware holds one section rigid. Everything else absorbs the price. And the outcome data on pain relief is sobering. For many patients, multi-level fusion provides no better long-term pain reduction than structured physical therapy. Not marginally worse, no better, but with dramatically higher risk. Not one of the 10 radiologists I spoke with said they would agree to multi-level fusion for degenerative changes alone. Not one. Ask your surgeon, what does the evidence show for my specific findings versus conservative management? Procedure number 2. Repeat epidural steroid injections without a confirmed diagnosis. When used correctly, targeted at a confirmed structural cause, epidural injections are legitimate and often helpful. I'm not telling you to refuse them. Here is the problem. They are increasingly used as a default response when imaging is ambiguous and the diagnosis is genuinely unclear. Patient has pain. Patient has findings on a scan. Inject the area, then inject again and again. The risks of repeated injections are well documented and widely underappreciated. Cortisone accelerates tissue breakdown over time. Studies show that beyond 2 to 3 injections, additional treatments provide diminishing returns while cumulative risk climbs. More troubling, injections used without a precise diagnosis can mask symptoms of a condition that genuinely requires investigation. Pain temporarily suppressed is pain not being properly understood. The radiologists were unanimous. Injections with a clear structural target and a defined endpoint, acceptable. Injections used repeatedly as a substitute for a diagnosis, not something any of them would agree to for themselves. Ask before any injection. What specific structure are you targeting, and what do we do differently if this doesn't work? Procedure number 3. Spinal surgery based on imaging findings that don't match your symptoms. This is the one that concerns radiologists most, and it is more common than anyone openly admits. Here is how it happens. A patient has back pain. An MRI shows a herniated disc. A surgeon says, "There it is. That's the problem. Let's fix it." Except the patient's symptoms don't match the disc level on the image. The pain pattern, the neurological signs, they point somewhere else entirely. The finding is real, but it may not be the cause. Every radiologist trainee learns this principle. Treat the patient, not the picture. A herniated disc that doesn't produce the sensory pattern, the reflex changes, or the nerve tension signs consistent with that level of compression is a finding. It is not necessarily a diagnosis. Every radiologist I spoke with said the same thing. If the MRI and the clinical picture don't match, they would not proceed. They would get a second opinion. They would insist on full clinical correlation before agreeing to anything. Ask your surgeon, does this finding directly explain my specific symptoms, and what clinical tests confirm that? Have you ever been shown a scan and told surgery was the only option? Write it in the comments. I want to know how many of you have heard those exact words. Procedure number 4. Vertebroplasty for compression fractures without severe refractory pain. For patients with debilitating pain from a compression fracture that hasn't responded to conservative management, cement injection can provide real relief. But here is what radiologists know, and most patients never hear. 2 landmark randomized controlled trials, published in the New England Journal of Medicine, compared vertebroplasty against a sham procedure. Both found no significant difference in pain outcomes between the real procedure and the sham, none. For a fracture found incidentally on imaging, or for pain that is manageable with conservative treatment, the radiologists I spoke with would not agree to cement injection, because the evidence that it helps is genuinely weak, and the risks, cement leakage, pulmonary embolism, all adjacent fracture are real. Ask your doctor, Am I in the specific patient group where this procedure has shown benefit? Procedure number 5. Spinal cord stimulator implantation before exhausting every non-surgical option. For patients with failed back surgery syndrome or specific neuropathic pain conditions, stimulators can be genuinely life-changing. I want to be clear about that. But they are increasingly offered earlier in the treatment process to patients who have not completed structured rehabilitation or pursued targeted interventional options. And a stimulator is not a reversible decision. Implantation carries real surgical risks. Studies show a significant percentage of patients require additional procedures within 5 years for hardware-related issues. Long-term evidence on sustained relief beyond 5 years remains limited. What the radiologist told me was not that stimulators are wrong. It was that they would not agree to one without being certain every less invasive option had genuinely been tried and had genuinely failed, not abandoned, tried fully. Ask, what is the complete list of non-surgical options I should attempt first, and how will we define what failed means? I want to tell you about a patient, 63 years old, retired school principal. She came to me holding her MRI results and one handwritten question at the top of the page. Is this really what's hurting me? She had lived with lower back pain for 2 years, a 4 out of 10, manageable. She still walked every morning, still gardened, still traveled. On her MRI showed multi-level degeneration and a herniation at L4 to L5. A surgeon had already recommended fusion. The paperwork was being prepared. She asked to speak with a radiologist first. I gave her 40 minutes. Her symptoms didn't match the surgical target. Not even close. I recommended rehabilitation instead. She left with a referral and a list of red flags. 14 months later, she sent me one line. I walked 4 miles in Portugal this morning. Pain is a 2. No surgery. Thank you. Here is what I need you to understand. This is the single most important thing I will say today. An imaging report is not a verdict. It is a description of structure. A surgical recommendation made from that description is not a mandate. It is the beginning of a conversation. You are not a passive recipient of what the scan says. You are an active participant in understanding what it means for your body, your symptoms, your life. The radiologist sees the image. The surgeon proposes the solution, but you hold the question. And the right question, asked clearly and without apology, is the most powerful tool in that room. Before agreeing to any spinal procedure, there are 4 questions every patient should ask. Write these down. Question 1. Does this finding directly explain my specific symptoms? Not the average patient's. Yours. Ask for the correlation to be explained precisely. Question 2. What does the evidence show for conservative management in someone with my exact findings? If outcomes are comparable with non-surgical treatment, you have time. Use it. Question 3. What is your personal complication rate for this procedure in patients my age? And surgeons track this. They know their numbers. A confident, honest surgeon will tell you. If the question makes them uncomfortable, that itself is information. Question 4. If I pursue rehabilitation for 6 months first, what is the realistic downside? Emergency situations aside, progressive weakness, loss of bladder or bowel control, most degenerative spinal conditions do not deteriorate dramatically in 6 months. Knowing the true cost of waiting changes everything. Has a doctor ever shown you a scan and told you surgery was your only option? Write it in the comments. Someone you know is sitting with an MRI or CT report right now, trying to understand what it means. If this helped you think more clearly, share it. That one share may be the most important thing you do today. Take care of your spine. Ask the hard questions. A second opinion is not disloyalty to your doctor. It is respect for yourself. Everything shared here is general medical information based on published clinical research. Every person's situation is unique. Please have a full, unhurried conversation with your own physician before making any decision about spinal treatment. That conversation, direct, informed, and without pressure, is exactly where good medicine begins. If you want more honest conversations about what your scans actually mean and what questions to ask before anyone touches your spine, subscribe, because that is exactly what this channel is built for. Hit the bell so you never miss what the people inside medicine already know.